Without any ado, let's go over. I just wanted to introduce Nigam as our first keynote today. He's a professor of medicine specializing in medical informatics at Stanford and serves as the Associate Chief Information Officer for Data Science for Stanford Healthcare. So really excited to hear these individual stories today. And as I said, use the chat liberally. It's not just for the keynote speakers, but also, conversations amongst all of us as these presentations are happening. So let's pass it off.
So it's fun to be here. I like the informal nature of this, and I 100% agree that we need to have a forum to talk about non-journal content. I don't know if a situation where publishing a PDF saved anybody. It has to be code and software that actually runs. Anyway, so today what I hope to discuss with you all is our journey towards useful, reliable, and fair models in healthcare. And now, by no means this is sort of a done deal. This is our experience to date, and what I hope to begin is sort of a conversation that we continue to have on where we go from here. All right, so this works. So first, I'll begin with the acknowledgements. This is the amazing team that makes it all happen. Obviously, this was pre-pandemic, literally like a couple of weeks. And the work today that I'll talk about, are you able to see my cursor?
Yes.
Okay, so it's Stephen Foll, this person here, a little bit from Scotty Fleming and Agatha and Alison Callahan and so on, Ethan Steinberg as well. Funding from a lot of places that keeps the whole thing going. So in order to anchor the conversation, I encourage all of us to adopt this timeline view of patient data. And on screen, what we have here is sort of an idealized patient journey going from left to right, the red dots being something of consequence happening along the way. And then depending on where we are in the healthcare ecosystem, we might see, claims data, we might see some more detailed ICD codes, medications, maybe dosages as well. We might see procedures and lab tests and clinical notes. We might get bedside monitors if we get into the health system. If we go out, we might have variables and molecular data, phone usage, browsing history, social media, and so on. Each of these track of information that's on here is something I've actually worked with myself. Well, with my students. You can imagine maybe 50, 70 such tracks of information that depending on the organization you're at and your research interest, you'd be dealing with on a routine basis. But two things remain constant about this view. And let's call this, just for argument's sake, a patient timeline object. No one has the complete track on one human being over, say, a decade. And no one has all the tracks on a human being, including the patient or someone, but like myself, I don't have all these tracks of information for myself. So we have this very sparse sort of data structure that we never fully see. And then with that, we try to do these two things. We're either trying to automate something tedious, alerting at the bedside, reading an X-ray, figuring out an HCC code that should not be left behind and whatnot. Or we're trying to do something that we could not do before, as in look at multiple channels of information and provide early warning or a recommendation of what needs to be done. That's sort of the very broad category of things that happen. Now, underneath, there's going to be a model that's doing this for you. And in this case, a model, just imagine a mathematical equation that's arbitrarily complex, linking inputs to outputs. Now, those models are essentially helping us do these two things. And I jokingly call this the equation of medicine, because most of the things we do in medicine can be reduced to this fundamental construct. We attempt to ascertain some risk, and if it's above a certain threshold, then we take an action. So if the risk of a major adverse cardiovascular event is above 7.5% in the next 10 years, then prescribe 40 milligrams of atorvastatin. Very rarely is life this clean and clear. The majority of the time, you have 5, 10, 15 of these things that you have to go through in your head. The threshold isn't always clearly defined. Sometimes the threshold is defined, but the risk estimate is weird or imprecise. And often what you should do is something that you have to like make it up on the fly. So out of the 3 things we need, the risk estimate, the threshold, and the what action should be done, we typically get 1 out of those 3, not even 2 out of the 3. And then we still have to make it all work. And on screen here, I sort of have the 2 projects on Stanford campus that are aligned with this 2 sides of the equation. One is about AI in healthcare. That's the one on the upper left. And then the bottom right is the Green Button project, which is about looking at similar patients and recommending what could be done given what happened to others. All right. As I said, underneath is a model. And for those of us in the hospitals and health systems, the model is one cog in the almighty workflow. The specifics of this workflow are not that relevant. In this case, this is a workflow for providing advanced care planning conversations. And the model, the thing in the red box, is an algorithm that triggers the workflow when the risk of mortality in the next year or so is above a certain threshold. Now that probability estimate in and itself accomplishes nothing. It's this rest of the workflow, the 21 steps and 7 handoffs over 48 hours. Those are the things that need to happen in order for the value to accrue to the patient. So this particular picture diagram is created by Margaret Smith, who's a collaborator of ours in this adventure. Okay, so my central point for today is that in order to make machine learning models useful, we have to, and reliable and fair, we need to evaluate them in a workflow-aware manner. Because using a model to guide care is inextricably linked to the subsequent actions it triggers or prevents. That's sort of the main point of the conversation. And so in order to unpack that point, I sort of view it as a sort of 3-pronged agenda. In order to get good AI-guided care, and I put good in quotes because we don't exactly know what good means in most situations, but it's an interplay of the model and its output, the intervention policy and the capacity, work capacity, how many of these can we do in a day? So that's the lower left. And then the benefit and harm of the intervention per se. Now, advanced care planning conversations are unlikely to harm anybody, but a lot of other interventions do carry genuine harm, and we do have to factor those in. And then on the model side, there's these conversations about generalizability across sites, reliability over time, interpretability, explainability, fairness. So we'll touch on a few of them today. So in order to wrap our head around this, what we've been thinking of this problem as the need of a delivery science for AI in healthcare, inspired from health services research. And we roughly break it down into, first we want to figure out, like, given a prediction or a classification, what is someone going to do? Can we write that out? And then a due diligence to say, is there an existing model we could just reuse? Because there's something like 250,000 risk stratification algorithms out there as of 2016. And that was before big data became fashionable in healthcare. So now it's probably 500,000. Then we get into the fun stuff of building the best model, the best equation. Is it fair? Is it reliable? But we also have to worry about practical feasibility. And can we get the data in time to do this by 6 a.m. if it's necessary? After that, we design the deployment, understand the utility, cost of action and benefit and the trade-offs. And then given the work capacity, what fraction of this utility can be realized? And that's something Karandeep and I have been chatting about quite a bit with Dr. Andrew Vickers. And then once we get something deployed, we have to monitor things in practice and then do a prospective evaluation to make sure we are getting the benefit that we thought we would get. So remember the colors. I'm just going to zoom out. And here are the things that we have done for all of the different stages for one particular example. And today, what we will do is, in the remaining time, go over sort of this portion of this workflow. The URL below, the paper below, gives you the details of some of the other steps. Okay, so everyone on this call, I would imagine, has some version of this in their head, in their experience, in their doing this. You might not have it with these nice colors, nothing to do with Google. This was just the default template. But we've gone through this collectively. And as a result of that, there's a lot of guidance on what shall thou do in order to not make mistakes along the way. So we did a sort of an inventory of all of those recommendations. So what we're seeing here as rows are the 16 or so recommendations. I often jokingly call them proclamations, that what shall thou do in order to make sure that your model is quote unquote good. So these are reporting recommendations. Across those 16, there's 220 unique items that we expect people to report. And then we bucketed them according to these various steps that I just outlined. And as you can see, the majority of focus is on how to develop models. But we need to start paying attention to, are the things we're doing fair? Do they have utility? Nothing on deployment. And then what are we going to do to monitor, as Yin was talking about just a little while ago? Because the model, the black box in his picture, is a tiny piece of this overall ecosystem. So this is just a level set, state of affairs right now. All right, so for usefulness, one of the things we did is build a little dashboard where, given your model's false positive rate, true positive rate, and your best estimate at the trade-offs of the cost in terms of what you do, the harms, and what may or may not happen, we just add this two extra things. We add this line, the utility line, technology from the 80s, nothing new there. And we add this little triangle saying, given your capacity, how far down, what zone is feasible for you. This other plot on the right is a little bit more interesting because we're just ordering the cases left to right over here. And then we have unit utility, and then we're just plotting this out and how far down the list can you get. So if you have a chase list and you're only going to go down there to 20 cases, well, you might have max utility here, but you're never going to reach it. So it's good to have these estimates up front. Then monitoring reliability over time. And you can view generalizability as reliability over sites. And there's a lot of computer science literature on how to do that. And what I'm showing you here is just a routine examination of the mortality prediction model. The dashed line is what's the best you can do when you train and test using the same year's data. And the solid lines are, if you trained in 2014 and you never retrain, you just keep using it, how does your AUPRC fall over time? And the orange ones are when you use simple count-based featureization, which is very common in healthcare. And the blue is if you use learned representations. So the punchline being, learned representations do help you preserve reliability over time. But we should be doing these comparisons on a routine basis. All right, on interpretability, the only thing I would say is that it could mean one of three things. That it could be about how the model produced the output. It could be about why and the causal variables. And then if the answer is that the first name of the patient, that's not going to cut it. But it is a good engineering explanation, which does not give you any causal sense. And then the third one is that often it might just be needed to establish trust. And I'm amongst the few people who argue that we should not be explaining until we know which of these sectors of the Venn diagram we're in, because otherwise we might actually, confuse the conversation. All right, finally, on the fairness piece, routine examination of performance across subgroups. On the left is the mortality model that we're using in our ACP work. Predicted probability against true probability. Yes, there is a little bit of a miscalibration, but this is our threshold at which we take action. And so, this is the likely difference that we might see. On the right-hand side is another model provided by a company that I shall not name, but you can see how the subgroup performance is different. Well, it's not different by subgroups. They're all within a tight range. So that's the good news. The bad news is it's not very well calibrated. And then what I'll leave with is that we often focus on the model when we talk about fairness. What we should be focusing on is the action, because absence of a systematic difference in the model output. So even if we fixed this red box, is not enough to guarantee that there will be absence of a systematic accrual in benefit. And let me show you a picture for that. So this is work by Professor Shah on our campus. And what we're looking at is on the x-axis, the risk of violent recidivism for an individual who is up for parole. The blue and the red are just distributions of the risk estimate for two subgroups. And now and they're accurate, well calibrated for those two subgroups. Now, if we induce a policy that says equal treatment for everybody, we result in this situation that certain subgroups will be withheld at twice the rate as others. So equal is going to lead to a systematic difference in the accrual of benefit. We can say, all right, our policy goal is to ensure that the top 10% high-risk individuals shall be withheld and denied parole. Well, in that case, we need two different thresholds for the two subgroups. Now, imagine being a politician having to explain that, saying we're going to have two different thresholds for two subgroups because the base rates are different. But that's the reality in which we live. And unless we face this hard choices, so this is equitable. We're going to withhold the top 10% here and the top 10% here. But it's two different thresholds. So equal is not always equitable, and equitable is not always equal, and we have to face that. So the proposal is to learn to be fair, or rather learn to be equitable. So we should be examining on a routine basis the percentage of the population that will receive the intervention given our threshold policy. So x-axis is going from 0 to upwards, and then counting, given that intervention and its net benefit, how many desired outcomes are we going to obtain? And then we get this Pareto frontier, and we should just look at the trade-offs implied by the different policies. Like, if I ask for demographic parity, what happens? If I equalize false negative rate, what happens? If I maximize utility, what happens? If I do random allocation, what happens? Only then we can learn what are our models actually going to do in the real world. And this kind of analysis, I think, needs to be done more. So I think this is my last slide. More at these URLs. And once again, thanks to this awesome group, and my contact info is up there.